Why is pain important? First of all, thank you very much for inviting me. I have to say, if the dermatologists here think that this is a whirlwind to see people like with your condition in one room, for a pain consultant, this is a mega whirlwind. I think I better just, some of you know why, and the other question is, why me? Why have I come here? I'll just show you where I normally work. On the top left there is Europe, and then there's England, and then stuck right in the middle of England is a clinic, Solihull, and that's where I work. And so why me? Me, because serendipitously, about 5 years ago, my dermatology consultant, who is the UK, there are 2 UK experts in Epidermolysis bullosa. Believe it or not, they are less rare than you, but they are still quite rare. He runs the national clinic for the EB patients, and he was struggling a lot with a patient because of pain. And I, at those days, was an anesthesiologist, and he called me, but I was also a pain consultant, and he called me down to see if I could help, and I could. And we then shared a few more patients, and before you know where you are, you're doing the clinic every week. And so I do a weekly clinic for EB patients. So, and up until a couple of years ago, I was actually the only consultant worldwide who did regular sessions, and I probably do more sessions than anybody else. Some people see them, but I sit in the clinic all the time. So I know a lot about EB pain. So Mary got my colleague Adrian to get me interested, and I have to say I am interested. I have to say it's not EB, and you'll say, well, we knew that, but so it's going to be a learning curve. And I have to say, the other thing I have to say is that it's a challenge. That to understand your pain is a challenge. This is not about, it's difficult, and it's different to EB. But the questionnaires have been tedious, maybe, difficult, but you've been awfully good, and hopefully we can pull the thoughts, we can scratch our heads, and we can move it forward. Pain is complicated. This is the definition of pain, and I think it's a nice definition because it releases you from worrying about the tissue damage. And I think sometimes people get worried because they haven't got outward signs, and it hurts a lot. In your situation, it's you've got a lot of outward signs, but your coping strategies are such, because you've always lived with it, there's a lot of, yes, I've got pain, but it's not that bad. And yet some people's feet, I've been amazed at how uncomplaining you are. So in that respect, you don't quite fit this definition, because you have a lot of signs. And I think the other thing that, as a pain consultant, we take on board a lot is that pain is a biopsychosocial problem. In England, we have an expression, you get out and out. That basically means you don't get, if something happens, something else will happen. And what this is telling you is that if you can't go to the pictures with your family because your feet hurt and you can't make it from the car park into the cinema, this impacts. This impacts on your family, it impacts on your relationships, it impacts on your whole world. And the end is not just about, hey, my feet hurt, it's the total family ongoing problem. So the spin-off of this is back in the EB clinic where my skin associations are. And so Dr. Hoggart drags me down and I start working in the clinic, and it's very obvious to me as a multidisciplinary pain consultant that the patients with EB have many psychological problems. And bit by bit, I drag a psychologist in, and now we have a fully functioning multidisciplinary team. So to look after these patients, we have a dermatologist, We have myself as a pain consultant. We have nurses to do the dressings. They have a lot of blistering, so they need lots of dressing advice. Jane, the girl upstairs who's helping with the research, she's a clinical nurse specialist in EB, so she knows a lot about skin and a lot about dressings. She does a lot of research with me, but her main job is that. We also have a podiatrist who does all the care for the feet. They, like you, have a lot of feet problems. And we have a psychologist who deals with the issues of multiple issues of growing up young and being disfigured, which is slightly different to your problem because overtly many of you are not disfigured. But there again, I had a conversation with a guy yesterday who told me about the impact of growing up with PC in the Bronx. He said, you didn't want to go there, you didn't want to tell anybody. And I took that on board because, so we're not talking about a pain here that has no biopsychosocial element. We're not just talking about my feet hurt. The thing about a pain consultant is that we start to broaden out the thoughts, that we're thinking about what else is happening to you and why, and how does that make the pain and the disability more or less. So, and that's why pain is important, but pain is complicated, and PC is very complicated. What else influences pain? Your age. Old people don't moan very much about pain. A lot of old people don't moan about pain because if you moan about pain in your back, you're admitting you're old. And some people don't want to admit that. Your gender. I hate this bit because women moan more about pain than men, and I think that we've got to do the research again because I don't believe it. Culture. How much you complain about pain depends on whether people, what the impact of complaining about the pain means. So back to the guy in the Bronx, he didn't complain about it because it brought up another mare's nest of problems. So similarly in Somalia, where they have to carry the water on their heads, there is no back pain in Somalia because if you complain about back pain, you can't carry your water, therefore you're going to die, so you don't have back pain. So cultural issues are important. Who do you think worldwide moans most about pain? Give us a vote for a country.
Belgium.
No? Another guess. One more guess and I'll tell you.
The French.
Canadians. There aren't any here, are there? I thought that was... There are? Okay. Your previous family experience, and I know that this is very powerful within your group because certainly in the EB world, they pass down the generations on how their coping strategies for their problem, and I'm sure that this is going on here. So how your family are coping, what everybody else is doing, influences what it does to you, your education and understanding, and that's why, hey, this meeting is so powerful, because your education and understanding is upskilling hugely. I mean, I know that you're all individual experts, but that's maybe, I'll be corrected by Mary if I'm wrong here, but maybe that's sometimes part of the problem, that individually you're divided. Once you come like this and you share your information, your upskilling, I presume, is huge, and that will help. Maybe not the pain, but it helps the sort of understanding, and then your fears, what the pain means to you. One guy said to me, my mum said I had to be good at school because if I wasn't good at school, I could never, my job, if I got a manual job, it would affect my income. I'd never be able to do it. That puts a lot of pressure because what your feet are doing does not make you more or less able to do an academic job, does it? So pain is very, very complicated. You can't treat it until you understand it. And one of the problems is that there's different types, and then when you get the different types, you've got different medications. So what are the types? There's the acute pain, and that's easy, it's the pinprick that you feel. Then there's the chronic pain, which is the area that your condition is in, but occasionally it flips back into the acute. And then you take the chronic and you divide it into the nociceptive, the neuropathic, and then the mixed. Some little pictures so you understand. The acute pain is the noxious stimuli, the little child with his hand in the fire. The nociceptive pain is the classic inflammation pain. This is the person with arthritis. That is a classic nociceptive. And then the classic neuropathic pain is the person with shingles, post-herpetic neuralgia, a herpes zoster infection, lots of vesicles, the pain doesn't resolve, you get nerve damage, and they get neuropathic pain. These are the classic examples. The acute pain, you can see what's going on, the person's burnt themselves, it's protective, you have increased nervous activity, and then the pain gets better when you have your appendix out, the appendix scar is better, you get better. But unfortunately, chronic pain goes beyond the healing. It doesn't serve a useful purpose, and I'm sure you will feel that about your pain. It's not actually helping you. You then get changes in your nerve signaling, and that's what all that sort of bizarre testing upstairs is going on for. Why, when does a pinprick hurt you in comparison to when does a pinprick hurt a normal patient? And it affects health and function. Certainly the surveys now are showing that people who have long-term chronic pain will actually die younger. You have, this is the same thing again, nociceptive pain, neuropathic pain. Neuropathic pain divides into peripheral and central, and then there's a group that are mixed. So, nociceptive fiber pain is activation of peripheral nerves, but neuropathic pain is caused by a primary lesion or dysfunction of the nervous system. So in other words, the nerves have learnt incorrect information. They have damage to the nerves themselves, and they cause atypical symptoms. Now the atypical symptoms that a neuropathic pain might cause is burning, shooting, tingling. The story that I've been hearing of people hanging their feet out overnight, that is suggestive of neuropathic pain. So this is how it becomes complicated, because people who hang their feet out overnight think they're going slightly mad. This is not normal. I'm not going to tell the doctor because this is slightly mad. He thinks I'm being annoying, and so I don't tell him. But in fact, the story is suggestive of a certain type of treatment that might help. Nociceptive pain is caused by activation of the nociceptive fibers. It's easily decided by its location. You all know what it feels like when you prick your finger, the quality, the character, and it's managed by opioids. So opioids will close the relay of the information up to the brain. That's why when you've had your appendix out, you've all had morphine to cover the pain, and this is how standard practice. And the information to the brain goes down when the problem has resolved. Unfortunately, if you have a chronic nociceptive pain, the information keeps travelling, and this is when the information to the brain starts to change. If you keep pummeling the brain and giving it the same information, different things will happen, and you can get proliferation of peripheral nerve fibers at a place of pain simply because that part has sent up information with such regularity. This is, as I said, the classic neuropathic pain. You get spontaneous pain and hypersensitivity in the area. So this sort of person, I don't know if any of you have had shingles, in fact nobody I have met so far here has had, but if you touch slightly on this chest, this person will howl with pain because they are so sensitive. They have an intense pain which is often persistent and recurrent. And the downside of having a long-term erratic pain is that you get severe comorbidities and a poor quality of life. So, this is the list that any pain consultant will give you to show you where pain is. So you've got your nociceptive pain, you've got your arthritis, your headache, your ischemia, your cancers. In the middle, you've got your classic mixed pain, because some people have a bit of this and a bit of that. So you've got your back pains, a lot of cancer pain is mixed. And then you have your more classic neuropathic pain, which is your shingles, your diabetics, HIV. Some people after a stroke might have a central pain, people with MS. And one of the things I think is important that you see when you look at that is that skin is not on the radar. There is no pain consultant who is interested in skin. When I talk about it at the pain when I talk about it at international meetings, nobody is aware. My daughter is a medic. I'll tell you this story. I shouldn't be, because I hope I'll moan if I go over time. But my daughter is a medic, and so like all other medics, medical students, they need to make papers. And she said, "Mum, can I make a paper for a poster so I can get some points?" I said, "Okay." And so I had a whole pile of papers from my EB patients, and she put them together, the questionnaires with the clinical signs and whatnot. And she did this beautiful poster, and we take it to Lisbon for an international meeting on pain, and people were so wowed that there was this group of patients with EB who had pain who they'd never heard of. She won a prize. But it wasn't because it was that wowy science. The science was actually quite low grade, but it was the novelty. This is novel, the idea that people with skin can have pain. So this is why I think that you have been very poorly served. I have yet to meet anybody who's seen a pain consultant, and in fact, I'm getting a distinct impression that you're not even telling your doctors you've got pain. You're going in and buying it over the counter. Now, maybe that's good enough, but it's not helping in terms of raising awareness about your problem. Anyway, to go on. The mixed. As you can see, back pain, 63% mixed, a little bit neuropathic, a classic neuropathic pain, a lot of neuropathic, a bit nociceptive, and cancer evenly divided. So a lot of pain is mixed. The question is, where do you sit? Are you mostly neuropathic, or are you mostly nociceptive? Once you've decided where you are in that spectrum, then you can make more informed choices about the medications that might help. Chronic pain is not isolated. We've talked about getting to the pictures, and it impacts on all aspects of life. This is a study about neuropathic pain, and we accept this in the pain world, that if it hurts, you don't sleep. You then have the follow-on impact of lack of energy, you're drowsy, depression is high, anxiety is high, and finally your appetite is poor. You relate the pain to the sleep disturbance, and the sleep disturbance is related to anxiety and depression. So you're going round and round in a chronic downward spiral of problems that are firing off in all different directions. Sleep. Pain consultants are very aware of the importance of sleep. Sleep physicians do a lot of research on sleep, and I spoke to one of the top gurus on sleep, and I said, "How is sleep going?" And he said, "We've researched it for 50 years and we still don't know why people need it. But we do know that animals do it, so we carry on thinking it's important." But there is a strong relationship between sleep and pain. If you can't sleep because it hurts, it affects your sleep quality, and that in turn exacerbates your pain. It's been shown that if you can get a person who's in pain a good night's sleep, it's equivalent to acetaminophen, I call them paracetamol, Tenolol, thank you. I can't get my mouth around it. Sleep is important, and I've heard of a lot of people who are hanging their feet out over the edge of the bed, and I'm just saying to you, think about getting yourself to have a good night's sleep, and maybe improve your analgesia before you go to bed, because if you get that good night's sleep, the following day might be better. Nerve activation requires different treatments. This is the pain pathway, and what you have pain is not just going up. Pain management is also going down. The up fibers, the ascending pathway, is modulated by opioid receptors. So at spinal level and at brain level, the opioid receptor will block the pathway. However, pain is modulated also by descending fibers, and descending fibers are both blocking the pain, and unfortunately 5-HT component facilitates the pain. So you have this spiral of things going up and things going down. And so descending control is important. Certainly there are certain types of pain that are still unmanageable. Fibromyalgia is a case in point, where the understanding of fibromyalgia, we're coming very around to seeing it as functional MRI has shown that the blood flow through the brain is different in patients with fibromyalgia, but there is no medication for them. But if you can change the descending control, you can actually help people with fibromyalgia, and the best way to help descending control is to cognitive behavioural therapy. Am I getting moved on? I thought I had till 12 o'clock. Oh, can I finish?
Yes, please. Should we let her finish?
Yeah.
I just wanted her to know, because sometimes they don't know whether they're till 1 o'clock or 2 o'clock.
No, I thought it was till 12 o'clock. Anyway, sorry.
It's okay.
So cognitive behavioural therapy is a way of helping this descending control. And I just say that to you because one patient mentioned to me that they'd been recommended an antidepressant for pain, and that's why, not because they are depressed, but because it's affecting the descending side of the control system. So this is how the types of pain, acute, I put it in colours because in the different forms, I'm showing you again how they work. What that little thing tells you is these are all the different drugs that are available. These are all the different ways of managing neuropathic pain with all the different types of antidepressants, anticonvulsants, and opioids. At the bottom you'll see a thing saying NNT, and you'll see that most drugs are around an NNT of 5. What that actually means is that 1 in 5 patients will be helped. That's what NNT means. So in other words, if you're using a drug and trying to find out if it's helpful, 1 in 5 patients will have a 50% drop in pain. If you're taking a condition like PC, where so few people have the problem, to understand and find which drug will help you best is going to be an incredible challenge, because most pain medications are only helping 1 in 5 anyway. And at best, an opioid is helping 1 in 2, 1 in 2.3. So where we are with pain management is still in the dark ages, and people with very rare complications make it even harder. NNH is number needed to harm, and here you want to be whereas before you wanted a low number, here you want to need a high number, because it's no good helping people with their pain if in fact you're making other things worse. And obviously a lot of you are very aware of that, and that's why an awful lot of you are avoiding medication, because you're worried about the harm. So what does all this mean to you? If 25% of patients with diabetes diabetes have neuropathic pain? What percentage of patients get neuropathic pain? And does it matter? Well, no one knows. Nobody has got any awareness of neuropathic pain and skin conditions. I've done the first research on EB, which is obviously my homeland, and I've shown that these are the different forms of EB. EB simplex is actually the dermatologists will all know the one that they probably see the least, because it's the most common and is the least have the least problems. But in fact, they have the greatest pain. And junctional, which is a very severe form, have a lot of pain. Dominant dystrophic, which actually is not as bad as recessive dystrophic, have a lot of pain. But even the recessive dystrophics, and these are people who can lose their whole hand, they will have no fingers, they just have stumps, don't have as much pain. So they outwardly are very distressed, but don't have as much pain as their other brothers. So this is how it looks as in bar charts. And just to let you know that the thing that most people talk about as being really dreadful is diabetes, and they're right down there. So there is a lot of pain in skin. Why is identifying neuropathic pain important? It's important because classically, if you have neuropathic pain, you have more pain. That goes with the territory. So if it hurts you more, the chances are you might be neuropathic. They don't get a good response to treatment, as you can see from the percentage relief with treatments, and that's information that we got from the BPI, which you likewise have filled in, so we'll see what response to treatment you get. So we're here to understand what the pain in PC. We've given you the questionnaires. You've been wonderful about filling them in. We're doing the quantitative sensory testing, all this pricking, all this localizing of your sensory access. Quantitative sensory testing is susceptible to many extraneous factors, which is why some of you have been wearing earmuffs and things like that. You've got to note the clinician has to understand the results, so that's why you've had these talks to me, so that I can look at your results and understand. That's why the girls are always calling me in, maybe if you've been there, to see me come in, because they want to talk about this, it's not quite right, we've got to get this right, we've got to understand it. So it's a bag of nails, but we're trying. We're going to measure your sensory thresholds, your control, all your different points. We're going to compare your results to healthy adults, poorly appreciated, poor understanding, and our aim is to help the understanding. If we help improve the medication, then hey, that's a bonus. But at the moment, you're right out in the wilds. People have just got to understand your pain. A voyage of discovery. And I'm off because Mary's going to kick me out.